Good afternoon, ladies and gentlemen. My name is Rachel, and I am on behalf of Vericom. We appreciate you taking time off your busy schedules to join us today. First of all, I would like to introduce our speaker. And our speaker today is a very famous Dr. Mina Moheb from Egypt. He is an endodontist, a bioceramics developer, and he's a researcher who has his own private practice for endodontics. So please welcome Mr. Moheb.
Thank you. Thank you. Bioceramics in daily practice. Hello, everyone. I'm Dr. Mina Moheb, endodontist from Egypt, and today I'm going to share my clinical experience with you about Woodroot ST and Woodroot PT. Woodroot ST is a pre-mixed bioceramic sealer that comes in a syringe form, while Woodroot PT is a pre-mixed bioceramic putty that comes in a capsule form. Composition: both are composed of calcium aluminosilicate compound as a bioactive component, zirconium oxide, which does not cause any discoloration, and a thickening agent. Uses: of course, Woodroot ST is used as a permanent root canal filling material in conjunction with gutta-percha, while Woodroot PT is used in vital pulp therapy, either direct or indirect pulp capping, pulpotomy, either partial or complete pulpotomy, regeneration, revascularization, in lateral and focal perforation repair, and in apical surgery as a retro-filling material, in epixification procedure as a putty plug, and in internal and external root resorption. Nowadays, there are so many studies that support the use of bioceramics, and here is a recent study that was published in July 2023, a critical review of the material properties guiding the clinician's choice of root canal sealer. In this study, they compared 35 PC sealer worldwide according to the percentage of the calcium silicate in the composition, and they classified the hydraulic cement as follow. Low charge, which is lower than 20% of calcium silicate. Medium charge, which is higher than 20 and lower than 40. Higher charge, which is equal or higher than 40. According to the material safety data sheet of Vericom, Woodroot ST contains 50 to 60% calcium silicate, which is considered one of the highest PC sealer worldwide in calcium silicate content. What is hydraulics? Simply, hydraulics is the injection of the bioceramic sealer into the root canal system, then applying the master cone to the full working length, which act as a piston that push the sealer into any susceptible microanatomy that may exist. Is it powerful enough to fill the whole root canal system to get a 3D obturation? Let's find out. Look the video. Here is a quick video that shows the material consistency and flowability while injected in a plastic block where 3 lateral canals were simulated. Just injection of the sealer, and it flows through the lateral canals. It's very long lateral canal, just with the sealer only. After that, you will put your master cone to the full working length, tear off the gutta-percha at the orifice level, and do some coronal compaction, and you're done. Here are the examples. Here are 2 tiny lateral canals filled related to upper second premolar. Here is a lateral canal filled related to upper lateral incisor, a lateral canal filled related to upper canine, a lateral canal filled related to lower second premolar. Here are 2 tiny lateral canals filled using Woodroot ST. Here is an isthmus area filled related to upper first premolar, a lateral canal filled related to the mesial root, and an apical delta filled related to the distal root of lower second molar. Here is a lateral canal filled related to the mesial root of lower first molar. The 3-year recall, the lateral canal still exists and is still filled with the sealer, and the sealer did not wash out, did not resorb by time. It still exists filling the lateral canal. Here is a lateral canal filled related to the medial root. In the shifted X-ray view, shows that the isthmus area was completely filled with the sealer. And here is a 5-month recall, shows complete healing, and the lateral canal still exists, did not washed out by time. Here's an isthmus area filled related to the medial root, and 3 lateral exits filled related to the distal root of lower first molar. Here's a lateral canal filled related to the palatal root of upper first molar with 4 roots. This is a type C lower second molar. I wasn't able to achieve patency, so I injected the sealer and added tapered auxiliaries. After I seared off the gataperca and I did some coronal compaction, I got 2 lateral exits filled with the sealer. Here is the 3 months recall after indirect composite restoration. The lateral canals are still filled with the sealer. Another case of inability to achieve patency in the distal root of lower first molar. After I injected the sealer, I got a tortuous lateral exit that was nearly impossible to be negotiated with hand files, filled with the sealer. Here is a lateral canal filled related to the palatal root and 2 lateral exits filled related to the mesiobuccal and distobuccal root of upper first molar. Here is a third case from a colleague for separated file management in the mesiobuccal canal. I decided to bypass the separated instrument from the mesiolingual as both canals were confluent, joining in one apical foramen. And I wasn't able to achieve patency in the distal root. After I injected the sealer, I got an abrupt 90-degree lateral exit filled with the sealer, and then shifted X-ray view shows the confluence point. A lateral canal filled related to the distal root of lower first molar. Here is a lateral canal filled related to the medial root of lower second molar. The first molar is extracted. Here are 2 tiny lateral canals filled related to upper second premolar. 2 tiny lateral canals filled related to upper second premolar. Here is a lateral canal filled related to upper second premolar. Upper central incisors. Upper central incisor has more than 40% incidence of accessory canal. The X-ray on the left is a lateral canal towards the buccal. The X-ray in the middle are 2 lateral canals. Here the sealer traveled a long distance to fill this one. And the X-ray on the right are 2 accessory canal that divide from the main canal and return back again to the main, which is called loop. Here's another loop filled related to upper second premolar. Another loop filled related to the mesiobuccal root of upper first molar. Here are 3 tiny loops filled related to the palatal canal of the upper second premolar. Where root ST will help you achieve the optimum apical seal on almost all types of cases, especially in the following case scenario. Long roots more than 25 mm, extremely curved roots, multi-planar curvature, H-shaped curvature. In case of conservative shaping, teeth with limited accessibility and limited mouth opening, teeth with external root absorption, compromised roots for strengthening, large apical lesions as it promotes healing. Here are the examples. Multi-planar curvature combined by conservative shaping related to the medial root of lower second molar. Multi-planar curvature combined by conservative shaping related to upper second premolar. Multi-planar curvature combined by conservative shaping related to lower wisdom. Cases of curved roots, this upper second molar, the 3-year recall. Cases of long roots, this palatal canal was 30 mm in length, while mesiobuccal and distobuccal was 28 mm in length. This canine was 32 mm in length. Again, long and curved roots. Multi-planar curvature combined by conservative shaping related to upper first premolar. There is no fear of extrusion of the bioceramic material into the bone, but caution should be taken care not to extrude near any vital structure, like inferior alveolar nerve, mental nerve, or maxillary sinus. Multi-planar curvature combined by conservative shaping related to the medial root of lower second molar. In case of conservative shaping related to upper second premolar with 3 canals. Conservative shaping related to the mesiobuccal root of upper first molar with 3 canals. Here are 2 tiny lateral canals filled related to the palatal root. The 1-year recall shows the lateral canals are still filled with the sealer, and the sealer did not washed out. Separated file retrieval, root strengthening. When we remove a separated file, we lose some dentin. We compensate the lost dentin using bioceramics as it bonds to dentin and act as a monoblock. Here, after I retrieved the separated file, I compensated the lost dentin using bioceramics. The 1-year recall shows complete healing. Another deep retrieval. After I retrieved the separated file, I compensated the lost dentin using bioceramics. Look where root ST penetrated through this furcal canal related to the furcal radiolucency. It is 1 month recall after clown placement. The patient is completely asymptomatic. Here, after retrieval of the long large separated instrument, we compensated the lost dentin using Bioceramics. Again, after we retrieved the separated file, the H file, we compensated the lost dentin using Bioceramic. Again here. This case, after I removed Gataperca and the separated file, the canals were oozing exudate, and I had to finish in one visit. So I injected the sealer and finished the case. Look at the size of the reducency. It's massive. Here is the 8 months recall, shows complete healing, and the sealer is still the same way it is, did not wash out, did not resorb, despite the exudates that exist. But thanks to the quality of the material, the sealer survived. Again, after I retrieved the separated file, I compensated the lost dentin using Bioceramics. Here is an interesting case. Actually, it's a simple retreatment that went to very difficult. I separated 4 instruments in the mesiolingual canal, and an XB endoshaper was separated beyond the distal apical foramen. Here is after retrieved the distal separated file and the 4 files in the mesiolingual canal, and here is the immediate post-obturation using root ST. In cases of limited accessibility and limited mouth opening, this is a lower wisdom. This is another tough curved wisdom. This is another wisdom where I got anastomosis in the mesial root and a loop filled related to the distal root. In case of large lesions, look at the size of the reducency related to the mesial root. The 2-year recall shows healing. Here's another retreatment case through an Emax crown. The X-ray in the middle is the immediate post-obturation. The 3 months recall shows significant reduction in reducency size. Here, after 1 year, the reducency almost disappeared. Here a case I did 5 years ago. The 3-year recall shows complete healing, and the lateral canal is still filled with the sealer, and the sealer did not wash out. Okay, now let's talk about another subject, which is vital bulb therapy. Anyone here practicing vital bulb therapy? Raise your hands, please. Anyone? Okay. Today I'm going to show you another different level in vital bulb therapy, so stay focused, please. AAE positional statement on vital bulb therapy. Vital bulb therapy techniques are means for preserving the vitality and function of the dental bulb after injury resulting from trauma, caries, or restorative procedures. Vital bulb therapy procedures have traditionally included indirect or direct pulp capping and partial or complete pulpotomy. Number 1, diagnostic consideration for vital bulb therapy. You should have sound diagnosis, should have correct diagnosis. The current AAE diagnostic terminology assigns vital bulb to one of 3 categories: normal, reversible bulbites, irreversible bulbites. Number 2, caries management. Complete caries removal. Any residual caries left behind will affect the prognosis. Number 3, use of sodium hypochlorite. Sodium hypochlorite is an antimicrobial solution that provides hemostasis, disinfection of the dentine bulb interface. Hemostasis can be achieved from 5 to 10 minutes, either via direct passive irrigation or on a sodium hypochlorite soaked cotton pellet. Number 4, use of contemporary materials in vital bulb therapy. It's better to use calcium silicate cement to have a better barrier formation than calcium hydroxide. Number 5, immediate placement of a permanent restorative material. Immediate restoration includes the benefit of prevention of the micro leakage, protection of the biomaterial layer, reduction of the post-operative sensitivity, and thermal conductivity. Summary: the primary goal of vital bulb therapy is the creation of optimal conditions for bulb tissue repair and preservation. Last paragraph: a pre-treatment diagnosis of irreversible bulbites is not necessarily an indication for pulpectomy, as more conservative treatment could be considered, so you can do pulpotomy in such cases. So, number 1, you should have sound diagnosis, correct diagnosis. Number 2, complete caries removal, no caries left behind. Number 3, use of sodium hypochlorite for disinfection and hemostasis. Number 4, use of the bioceramic material on the exposed bulb. Number 5, immediate placement of a permanent restoration. You should do all 5 steps in one single visit. Root PT different clinical applications: vital bulb therapy, indirect pulp capping, direct pulp capping, pulpotomy. Here are the examples: direct pulp capping related to upper first molar, direct pulp capping related to upper first molar, direct pulp capping related to upper second premolar, Direct pulp cavitated to upper second premolar. Direct pulp cavitated to upper second premolar. Again, direct pulp cavitated to upper second premolar. Here is the exposure site, capped with spotty, immediate post restoration, immediate post X-ray, all in one visit. Again, direct pulp cavitated to upper second premolar. Exposure site, capped with spotty, immediate post restoration, immediate post X-ray, all in one visit. Direct pulp cavitated to upper second premolar with 2 exposures. Direct pulp cavitated to upper first molar. Here is the 1-year recall, shows barrier formation. Tooth is completely asymptomatic. Response normally to cold with no any radiographic finding. Direct pulp cavitated to upper first molar. Exposure site capped with spotty. Immediate post restoration, immediate post X-ray, all in one visit. Here is the 1-year recall, shows barrier formation and tooth is completely asymptomatic. Response normally to cold with no any radiographic finding. Here a case I did 5 years ago. Here is the immediate post direct pulp capping. A lot of the material is inside the bulb horn. The 3-year recall shows barrier formation. Here is a barrier that was formed. Tooth is completely asymptomatic. Response normally to cold with no any radiographic finding. Direct pulp cavitated to upper first molar. The 1-year recall shows barrier formation. The tooth is completely asymptomatic. Response normally to cold with no any radiographic finding. Direct pulp cavitated to upper second premolar. Direct pulp cavitated to lower second premolar. Remember this case, there is a hole in the crown of the first molar. We will discuss again later. Direct pulp cavitated to lower first molar. Direct pulp cavitated to lower first molar. It's a predictable and a repeatable procedure. Direct pulp caving related to upper central incisor. The X-ray on the left is immediate post direct pulp caving. The X-ray on the right shows narrowing in the bulb chamber, indicating barrier formation. The tooth is completely asymptomatic. Response normal to cold with no any radiographic finding. Yes, liner. Any liner you have. Yes. Here is the 1-year recall. Clinical image, there is no discoloration occurred in the center, so you are free to use this material in the aesthetic zone with no fear of discoloration, unlike most MTA brands that causes massive discoloration. So in case of the body, you are free to use in the aesthetic zone, no discoloration will occur. Direct bulb cavitated to lower second molar. Direct pulp cavitated to upper first premolar. Direct pulp cavitated to upper first molar. Direct pulp cavitated to lower first molar. Direct pulp cavitated to lower second molar. Here is the 3-year recall, shows barrier formation. Here is the barrier that was formed, and the tooth is completely asymptomatic. Response normal to cold with no any radiographic finding. Here is the barrier that was formed. Direct pulp cavitated to lower first molar. The 1.5-year recall shows narrowing in the bulb chamber. Narrowing means that the barrier was formed and the tooth is completely asymptomatic and responds normal to cold. There is no calcification occurs in vital bulb therapy. No calcification occur in vital bulb therapy. Direct pulp cavitated to upper first molar. Direct pulp capping in upper first molar. Direct pulp cavitated to upper second molar with 2 exposures, capped with putty, immediate post restoration, immediate post X-ray, all in one visit. Okay. Here's a 50-year-old male who came complaining severe pain related to his lower second molar. Upon taking radiograph, I found a deep carious lesion near the bulb related to the lower first molar. Now, what will be your treatment plan here, knowing that the first molar is completely asymptomatic? Simply, I did root canal treatment to the lower second molar as the bulb was inflamed and has to be removed, while I did direct pulp capping to the lower first molar as the bulb was healthy and could be kept alive. But a meticulous preoperative X-ray analysis has to be taken care to avoid exposure of the projected distal bulb. Here is a 1-year recall. Both teeth are completely asymptomatic. Both are with no any radiographic finding. The first molar responds normally to cold. The 2-year recall, both teeth are completely asymptomatic. Both are with no any radiographic finding. The first molar responds normally to cold and a barrier was formed. Here is the barrier that was formed after 2 years. Direct bulb cavity to lower first molar, direct bulb cavity to upper second molar, direct bulb cavity to lower wisdom, direct bulb capping related to lower second deciduous molar, lower E. Can we do direct bulb capping to deciduous teeth? Can we? Yes, we can. Indirect bulb cavity to upper first molar, indirect bulb cavity to lower first molar, indirect bulb cavity to lower second molar, indirect bulb cavity to lower wisdom. Partial pulpotomy related to lower first molar, the same 5 steps you have to do either in partial and complete pulpotomy. You have to do all 5 in one single visit. Partial pulpotomy related to upper first molar. Here is a 6 months recall. There is a barrier formed. Tooth is completely asymptomatic. Spondus normally to cold with no any radiographic findings. This means success. Partial pulpotomy related to upper first molar. Partial pulpotomy related to upper first molar. Partial pulpotomy related to lower first molar. Partial pulpotomy related to lower first molar. Pulpotomy related to lower second molar. Pulpotomy related to upper first premolar. Here is what I do in vital bulb therapy cases. This will answer your question. You just adapt the body using an adhesive brush. We have to remove the excess from the margins to enhance the bonding. You can't leave the excess material on the margins. You're going to have a proper bonding. This is the liner I told you. Okay, you have to protect your material. After that, you remove your excess material. You can do sandblasting. I use sodium hypochlorite, full strength. You can use alcohol also. And you are free to do your final restoration. You have clean margins now. The previous cases was diagnosed with reversible bulbitis. Starting from this case, the diagnosis is irreversible bulbitis. After achieving hemostasis, we'll root PT on the exposed bulb, immediate post-restoration, immediate post-X-ray. The patient reported completely asymptomatic after 3 days. Here, it's a bulb stone. After I removed and achieving hemostasis, we'll root PT on the exposed bulb, immediate post-restoration, immediate post-X-ray, all in one visit. The patient also reported completely asymptomatic. The same, but in young age patients. Pulpotomy in lower first molar, pulpotomy in lower first molar, pulpotomy in upper second deciduous molar, upper E, pulpotomy in lower second deciduous molar, lower E, pulpotomy in lower second premolar. Okay. Root canal treatment and vital bulb therapy in the same tooth. Can we do that? Can we do root canal treatment and vital bulb therapy in the same tooth? Let's find out. Here's a 9-year-old boy who came complaining severe pain related to his lower first molar. Upon taking the graph, I found a deep carious lesion near the bulb and the incomplete maturation of the distal root. The distal root wasn't fully formed yet. Okay. Upon exposure, dark red profuse bleeding came out with little amount of pus. After accessing the tooth, a dark red profuse bleeding came out. After trials to control the bleeding, this image told me that the medial bulb is unhealthy and has to be removed, while the distal bulb is healthy and could be kept alive. So I capped the distal bulb using root PT, and I did root canal treatment to the mesial root only. Here is a confit X-ray. Here is immediate post-obturation and capping using post-ST and PT. Is 18 days recall. The boy is completely asymptomatic. The 1 month recall after a stainless steel crown placement. The boy is also completely asymptomatic. And here is the clinical research that supports the procedure. Combination of non-surgical endodontic and vital pulp therapy for management of mature permanent mandibular molar teeth with symptomatic irreversible bulbitis and apical periodontitis. And here is the 14 months recall. There is a complete maturation of the distal root. This means that the bulb stayed alive and continued the growth of the distal root. Here is the 1 month recall, the 14 months recall. I think the difference is crystal clear. Here is part of the literature about vital bulb therapy, so please stay focused. Treatment outcome following direct bulb capping using bioceramic materials in mature permanent teeth with caries exposure, retrospective study. Success of direct bulb capping using mineral trioxide aggregate and calcium hydroxide in mature permanent molars with bulbs exposed during caries tissue removal. 1 year follow-up, randomized controlled trial. Conclusion: teeth with caries bulb exposures and reversible bulbitis can be treated successfully with direct bulb capping. MTA proved better than calcium hydroxide in terms of both success rate and pain intensity. Systematic review and meta-analysis, Journal of Endodontics, 2015. Direct bulb capping with calcium hydroxide or mineral trioxide aggregate, a meta-analysis. MTA has a higher success rate, results in less pulpal inflammatory response, more predictable hard tissue barrier formation. Pre-mixed bioceramics, a novel bulb capping agent. Conclusion: the pre-mixed bioceramic materials possesses favorable results and all the properties comparable to the currently recommended material for bulb capping MTA. The results are comparable or even superior. Evaluation of pulpal response of deciduous teeth after direct bulb capping with bioactive glass and mineral trioxide aggregate. Direct bulb capping a treatment option in primary teeth. Conclusion: direct bulb capping should not be disregarded as a treatment option in primary teeth. It is mandatory that the therapeutic procedure be performed precisely under complete asepsis, followed by the provision of a bacteria-tight coronal seal. Pulpotomy of symptomatic permanent teeth with caries exposure using mineral trioxide aggregate. Pulpotomy using MTA could be a good alternative for root canal therapy for management symptomatic mature permanent teeth with caries exposure. Success of coronal pulpotomy in permanent teeth with irreversible bulbitis, an evidence-based review. Coronal pulpotomy is an evidence-based, safe, and predictable treatment that can be offered to adult patients in teeth with irreversible bulbitis as a substitute to root canal therapy. Remember, the best root canal treatment is the one you can avoid. And the best obturation material is what God's created, which is the dental bulb. Root PT as a root canal filling material by obturation. Here I filled the distal root using root PT, while I filled the mesial using root ST. Here a case I did 4 years ago, 2 years after the patient came complaining severe pain related to the tooth. Upon taking a radiograph, I found a radiolucency related to the distal root only. So I retreated the distal root and filled using root PT. 2 days after, the patient reported completely asymptomatic. And here is the clinical research that supports the procedure: selective root retreatment, a novel approach. Here I filled all 5 canals using root PT. Here is the traumatized upper central incisor where I filled the whole root canal system using the putty. Here is a case of open apex. After I removed calcium hydroxide, I filled the distal root using root PT, while I filled the mesial root using root ST, the sealer, then root PT on top to push the sealer to go through the isthmus area that was filled with the sealer. And here is a quick video that shows the apexification or the putty plug related to the distal root using just simple tools, hand plugger, paper points, point brushes. You just take your increment, push it with any appropriate instrument you have. You can use paper points, you can use gutta percha points, you can use your hand plugger. ايه رايك؟ And that's it, you're done. You did your apical plug. If you wanna backfill using a taberka, it's okay. You wanna fill the whole root canal system using the body, it's okay. In the case of overextended, Gataberka through an open apex where I filled the distal root using wood root PT. Extremely curved and long roots, upper second molar. This is the case of upper second molar with extreme curvatures. Here is the master apical file for the canals. Here is the immediate post obturation using wood root ST. You cannot do any other obturation like this. Putty. Yes. Optional. You can use it, you can. Here I don't. Here is another X-ray view. Calcification management with the help of CBCT and Wilbex. This case has a trick, so please stay focused. This is a referred case from a colleague for inability to find the distobuccal canal. If upper first molar, I gave it a try to find the distobuccal canal. I couldn't. I suspected fusion between the distobuccal and the palatal root, so I injected Wilbex, which is a calcium hydroxide with iodoform, and I got a lateral canal filled, but I didn't find the distobuccal canal. So I filled the mesiobuccal and the palatal roots, and I put a drop of Wilbex in the search area for the distobuccal canal, and I took multiple shifted X-rays hoping to find the distobuccal canal orifice, but I didn't. And here is a drop in the search area. Then I sent the patient to take a CBCT. Here I used this drop as a reference or as a guide to tell me where I have to search, where I have to look. So it told me that I need to go 1 millimeter beyond the reference point after detection, and here is the immediate post-obturation. Bulb stone and multiple relucency management with 3, 6, and 10 months recall shows healing, and 1.5-year recall for direct pulp capping. If you remember this case, we did direct pulp capping for the lower second premolar. Unfortunately, there were a hole in the crown. Leaking food led to caries, hence pulp necrosis and apical periodontitis. After I removed the crown, I found a bulb stone blocking the canal entrances. Here is the bulb stone clinically. Here is the immediate post-obturation using wood root ST. The 3 months recall shows significant reduction in radiolucency size. 6 months recall shows more healing. 10 months recall shows almost complete healing. And here is the 1.5-year recall for the lower second premolar that was completely asymptomatic and responds normal to cold. Calcification management. Here is a referred case from a colleague for inability to find the mesiobuccal canal of lower second molar. After I removed the white calcific tissue using ultrasonics, I was able to detect the mesiobuccal canal orifice, confit X-ray, and here is the immediate post-obturation. Here is a case of complete calcification related to upper first molar. At first, I was able to detect the mesiobuccal and the palatal canals. After a while, I was able to detect the distobuccal canal, and here is a confit X-ray for all 3 canals. Look where I found the distobuccal canal. Actually, it's in a bizarre location. It's on the distal margin, which is very bizarre. A perforation occurred during search for the distobuccal canal, and here is the immediate post-obturation and perforation repair using both ST and BT, and here is an apical delta filled related to the mesiobuccal root. Hydraulics power. Bioceramics are a real savior and a game changer material. How? Perforation repair. Here's the referred case from a colleague for inability to find the distobuccal canal and for perforation repair. Here is the perforation site. This red point is the perforation site. After I removed the calcific tissue, I was able to detect the distobuccal canal. And here is the immediate post-obturation and perforation repair using the sealer only. It's a tiny perforation. Here is a male dentist came complaining his lower second molar After I removed the getaperca, I found a tiny perforation in the furcation area. Here is after detection of the medial canal, confit X-ray, down backing, backfilling for the distal, and here is immediate post-obturation and perforation repair using Wound Root ST. Here is the 1-year recall. The patient is completely asymptomatic. Another perforation repair using Wound Root PT. Here a case I did 5 years ago. I did repair the perforation using Wound Root PT. Here is the 1-year recall. The part is still the same way it is. Did not resorb, did not washed out. Actually, it's a very tough for any bioceramic material. Did not washed out despite it's subjected to the oral cavity environment. I can block or repair this perforation using composite restoration. Here is the 4 years recall. The body is still the same way it is, despite the composite was ditched at the distal margin, but the body survived thanks to the quality of the material. Perforation repair during search for a calcified canals. Perforation repair during search for a middle medial canal. Here's the third case for perforation repair or for the inability to find the mesiobuccal canal. Here is the file in the perforation site. Here is the perforation site periphery after removal of the granulation tissue. After detection of the mesiobuccal canal, here is the confit X-ray. Immediate post-obturation using Wound Root ST. Immediate post-repair using Wound Root PT. And here is the immediate post-obturation and perforation repair using both ST and PT. Here is the 1.5-year recall, shows healing. Furcal canal. Here a case of lower second molar. During taking the working length using the electronic apex locator, I was able only to take the working length for the mesiolingual and for the distal canal only. Every time I put the file in the mesiobuccal canal, the apex locator keeps giving me that I'm out of the root. So I decided to take multiple radiographs to see what's happening. Here's the file in the mesiolingual canal. There is no problem in this one. Here's the file in the mesiobuccal canal. It looks inside the root, but why the apex locator keeps giving me that I'm out of the root? So I decided to take a wider shift. It was clear that the file in the bone, so it was clear that it's a furcal canal. What's the furcal canal? It's a very short canal that starts and ends in the furcation area. It's about 2 millimeter length. This is how the axis looks. It looks like a C shape that connects the canals. This is before dryness. This is after dryness. The furcation area looks bizarre. Confit X-ray for the mesial and distal. Immediate post-obturation for the mesial and distal using Wound Root ST. Wound Root PT is a body in the furcal canal, and Wound Root ST in the isthmus area that connects the canal. It's an empty space and it has to be filled. External root resorption. Here is a case of massive external root resorption related to the distal root of lower first molar. Here is after repair. The 6 months recall shows significant reduction in radiolucency size, and the patient is completely asymptomatic. Here is a female colleague, female dentist, came complaining severe pain and swelling related to her lower first molar. Upon taking a radiograph, I found a large radiolucency related to a massive external root resorption related to the distal root. Decided to give it one more chance after getaperca removal from the mesial, and here is the large H file throws the resorptive defect. Actually, it's a very large defect. During getaperca removal, part of the getaperca was torn and extruded through the resorptive defect. I decided to obturate the mesial root first, so I blocked the distal canal as it was oozing blood and exudate. So I had to block it to be able to fill the mesial root. Here is after obturation of the mesial. I decided to do the same in the distal, and here is the immediate post repair. And this is how external root resorption may look alike in a radix root of a lower first molar. The 4 months recall shows significant reduction in radiolucency size, and the sealer is still the same way it is, did not washed out, did not resorb by time. This area is filled with blood and exudate, and the sealer can easily washed out. It takes 2.5 hours to 4 hours for the sealer to set, but thanks to the quality, the sealer survived. Here is 8 months recall, significant reduction in radiolucency size, and the sealer is still the same. And here is a conclusion from a study that was comparing different PC sealer worldwide. They found that Wound Root ST was found to be the most effective for attachment of human periodontal ligament stem cell on the set surface. Day 0, 4 months recall, 8 months recall, 2 years recall, the sealer is still the same and the patient is completely asymptomatic. Like we did the case today, the sealer did not affect. Intentional replantation and the crack management. Here a case I did in 2013, I did direct pulp capping for the lower first molar using calcium hydroxide. In 2017, signs and symptoms of apical periodontitis started to appear, so we did root canal treatment. In 2019, the tooth almost completely healed. Unfortunately, in 2021, a horizontal crack pattern started to appear, and here is the crack was pigmented using methylene blue dye. I decided to give it one more chance. I removed the gataperca and I filled the whole root canal system in both roots using root PT. Unfortunately, the patient still have symptoms, so I extracted the tooth, cut the apical part of both roots, and put back again into the socket. And here is the immediate post-replantation. The 3 months recall shows significant reduction in radiolucency, and the patient is completely asymptomatic. Here's a referred case from a colleague for separated file management in a dilacerated mesolingual canal of lower second molar. I wasn't able to neither bypass nor retrieve the separated instrument, so I extracted the tooth, cut the apical part of both roots, filled using root PT, and put back again in the socket 3 days after the symptoms subsided. Lateral canal scouting. Here, during a scouting of the distal root of lower first molar, a lateral canal was detected. Unfortunately, the file got separated inside the lateral canal. Here is the file separated inside the lateral canal. After obturation, the lateral canal got filled with the sealer. So the sealer fixes the problem. Here, another lateral canal is scouted where it was easily filled using the sealer. Another scouting trial, a lateral canal was detected related to the distal root of lower first molar. Here is the immediate post-obturation where the lateral canal got easily filled with the sealer. Deep split management for non-microscopic clinicians. Here a case of upper second premolar with Vertucci type 7. Vertucci type 7 has the anatomy of 1, 2, 1, 2. I'm going to tell you some tips to manage such anatomy. Number 1, stick to the reference point, your buccal cusp, your palatal cusp. Number 2, recurve or instruments, your hand files, your shaping files, your irrigation needles. Better to use polymer 1. Number 3, shape both canals together. How is that? When you start glide path for the buccal, you do the same for the palatal. When you start shaping of the buccal, you do the same for the palatal. Because if you shaped one canal to the master apical file, every time you put your file to start shaping the unshaped canal, the file will tend to enter to the larger canal. So you will find difficulty to enter the narrower one. This is what I meant by shaping both canals together. And number 4, of course, the hydraulic condensation technique for obturation. You recurve your sealer tip, inject the sealer, recurve your gataperca cones, insert to the full working length, tear off the gataperca, do some coronal compaction, and you're done. Another case of Vertucci type 7 related to upper first premolar, done on the same concept. Here is a mid-root split related to lower first premolar. During scouting, a lateral canal was detected after detection of the lingual, and here is the immediate post-obturation. Okay, this is another level in split management. This is a lower first premolar that was clear from the preoperative radiograph. It has one main canal and 2 tiny splits. During scouting trial, 1 split were detected, 1 split and the main canal, 2 splits were detected. Now, how I will obturate these splits? I cannot see them. What I will do? I tried to make gataperca harder. I recurved and put an ice cube, sprayed with endo ice, but I failed to put these gataperca points in the splits. So I decided to depend on another strategy. I decided to depend on the hydraulics power of the bioceramic sealer. So I chose the largest gataperca cone that gives me the toughest tug back. Then I did down and back the cone till the level of the splits. So I blocked the main canal. So after I inject the sealer and add the rest of the cone, the sealer won't escape through the larger canal. There were no escape either through the tiny splits. So the sealer entered through the tiny splits, and here is a lateral canal started to appear. We weren't aware of this lateral canal. After that, I added more tapered auxiliaries. Taper 4 or taper 6, no taper 2. And added more sealer. A very important step, you have to sear off the getaperca at the orifice level or below the orifice level by 2 millimeter and do some coronal compaction. It's a very, very important step. I got 2 lateral or tiny splits filled and puffed with the sealer, and the lateral canal was also filled with the sealer. So we relied on the sealer to fill these long splits. Here's another case of lower first and second premolar. The second premolar has multiple splits. During a scouting trial, 3 splits were detected. Here's a master apical file for the splits. Unfortunately, file was separated in one of the splits. Actually, it's a very, very tough bypass. I couldn't be able to fully bypass the separated instrument, so I decided to depend on the hydraulics power. Here is the confit X-ray. After injection of the sealer, the sealer penetrated beyond the separated file. And here is the immediate post-obturation for both the first and second premolar. One last case. Here is a case of lower first premolar that was a part of a bridge with multiple splits. During a scouting trial, 2 splits were detected, 3 splits were detected, 4 splits were detected. Master apical file for the splits, confit X-ray, and here is the immediate post-obturation using root ST. And here is a quote from my mentor, Dr. Alan Nasih: if you're always worried about failure, you will never reach out for success. Thank you, and I hope you enjoyed the presentation. Thank you. Thank you. Any questions are more than welcome.